So the first specimen is urine cytology. It's a washing cytology from the right renal pelvis. So because it is a washing cytology, the cellularity is high. In the background, we do see a lot of inflammatory cells. We also see a lot of debris-like material. Additionally, we start to see some more hyperchromatic cells with higher NC ratio but with marked degeneration of the chromatin. So overall, the background looks bad, but we still need to find some diagnostic cells. Then we go to some cell cluster. Then we identify groups of cells with very hyperchromatic chromatin and high NC ratio and with variation of the nuclear size and shape. So these looks like hyperurothelial carcinoma. The patient had the concurrent biopsy, ureteroscope biopsy. However, the biopsy was sent out as Airshow-Day with reactive urothelial cell. So there is a discrepancy between the cytology and the biopsy. Sometimes the biopsy actually get less material. So because the biopsy already signed out as benign, I think it would be a little bit difficult for us to directly call these hyperurothelial carcinoma, despite the morphology is highly consistent with the hyperurothelial carcinoma. So we will taper the diagnosis to suspicious. So for the upper tract urothelial biopsy or washing cytology, sometimes we need to have correlation. I think the patients still have hyperurothelial carcinoma, but just for some reason the biopsy didn't get it, or I don't know what's happened, and maybe they just get more Airshow-Day than the diagnostic cell in the biopsy specimen. So the clinician would still need to go further for these patients. So this was signed out as suspicious. For typical hyperurothelial carcinoma, the following two specimens are all voided urine specimens. Usually we will see tons of cells. Majority of them would be individual cells, so we like to see individual cells with higher NC ratio. In this specimen, the NC ratio is the cellularity is really high. However, majority of the cells do have marked degeneration or almost like a necrotic pattern. So the first thing that we know that this is not a normal urine cytology, because in normal urine cytology you won't see these markedly like a necrotic pattern. So it's definitely unusual. And the second thing is that we do see scatter, like a keratinization, like keratinized cells, which suggests that a lesion may have focal squamous differentiation. So overall, the cellularity is high, but the majority of the cells are all degenerated. However, we do see that the nucleus are mostly hyperchromatic. So I think originally the screener called these suspicious. I think this is perfectly fine. However, I think for this degree of necrosis and almost all the cells show this hyperchromatic pattern, we can probably just go further to call this positive for hyperurothelial carcinoma. We do have very scattered cells with more preserved morphology, so which is okay. So I think either suspicious or positive would be okay, but I think for this one, maybe we just call this positive. So the second specimen is very similar. So again, you do see marked degeneration as well as some keratinization. And the cell, although it's very difficult to find individual cell that is qualified for the diagnosis criteria, but you do see cell looks like these: hyperchromasia, coarse chromatin, high NC ratio. And in the background, a lot of cells do have similar morphology. So it is okay that we just directly call these high-grade urothelial carcinoma because we do have plenty of the cells. The background is totally abnormal. We also see some dyskeratinized cells. So this is reasonable that we just call these high-grade urothelial carcinoma. So despite the criteria for high-grade urothelial carcinoma in Paris system, usually that would require higher NC ratio, but in these two cases, you can appreciate that sometimes high-grade urothelial carcinoma cells doesn't have higher than 0.5, 0.7 NC ratio, but it is still a high-grade urothelial carcinoma cell. So sometimes we need to balance the cellularity and the other criteria as well. So this one we also directly call these high-grade urothelial carcinoma. So the patient can have further management for that. So let's move to the effusion specimen, body fluid specimen. The first specimen is coming from pleural effusion. The patient do have past history of lung adenocarcinoma. So in this specimen, we see most of the atypical cells are individual high-grade cells. So here you do see a gigantic cell with very big nucleus, very bizarre nucleolus, some bubbles in the cytoplasm. So this is a positive poorly differentiated adenocarcinoma. These as well, this as well. So most of them were arranged in single cells, some with small tight cluster, but these cells do have high-grade atypia. So this is compatible with the poor treatment response and recurrence as a poorly differentiated adenocarcinoma. So the second specimen is from the ascites. So on low power, you can already appreciate that we do have two cell population. Some of the very tight cluster of the cells looks quite abnormal. We go to higher power. Indeed, the cell does have typical feature of adenocarcinoma. We have a typical nucleus with vesicular chromatin, irregular nuclear membrane, and prominent nucleolus arranged in a three-dimensional glandular structure. So here as well, and this one, these very strange looking cells as well. Okay, so these are all adenocarcinoma, and the patient had a past history of gastric cancer. So most of the time, the gastric cancer, if it go to the ascites, it go to the peritoneum cavity, majority of them were signaling cell. However, rarely you can see intestinal type adenocarcinoma. So this is compatible with intestinal type gastric cancer. So the next specimen is coming from pleural effusion from an elder male. So on low power, it seems to be that most of the cell were single cell. A lot of them have higher NC ratio, so these looks like an inflammatory background. We do not see two cell population. That's say we do not see the tight aggregates of cells. But when we go to higher power, you can start to appreciate that these single cell, these individual cells looks atypical. So if you have a reference cell in the background, usually we will search for a mature reactive lymphocyte. The size of the lymphocyte is like this. And these cells do have enlarged nucleus, open chromatin, multiple nucleolus. So it looks like a plastic cells and with a TPR. So the nucleus is not rounded. You have several notches here and there. And the cell does show some degeneration type of change. Therefore, this is considered with sort of like higher proliferation and a typical cell. So when you see more of these type of cell, you are thinking about maybe this is a lymphoma, okay? So this looks like a high-grade lymphoma with large cell with pleural effusion involvement, and we do see like individual choleraceous cells, which means the cell is highly proliferative and underwent apoptosis or individual cell necrosis. So in the background, we do have a lot of these type of feature. So it looks like a plastic cells and it looks like a hematopoietic population. And then you go to the history, the patient was diagnosed with plasmablastic myeloma with mediastinal involvement. So that's reasonable that the cell was coming out of the mediastinum to the pleural effusion. So then we go to the morphology, then you can appreciate that some of these cells do have plasmacytoid feature, right? And with like a typical chromatin pattern similar to a normal plasma cell. So this is compatible with myeloma involvement. However, the morphology and the degree of individual cell necrosis looks pretty bad. So means that the tumor is actually more aggressive than the usual type of the myeloma that we see. And indeed, the patient already expired. So he don't have the diagnosis from the pleural effusion yet. He already expired. So this is a very bad tumor. So the next specimen is coming from pleural effusion as well. So this is actually a new patient. So for the pleural effusion specimen, we only have very, very scattered of these cluster of three-dimensional arrangement. So it looks like adenocarcinoma, but the lesional cells are very scant. So we check, because the patient is in the ER, we checked the medical history from the ER. The patient was actually has a very big tumor in the abdominal cavity, but also with a pleural effusion. So she received pleural effusion taping first, but it was suspect to have ovarian cancer. So this is possibly ovarian cancer with pleural effusion involvement. So she submitted 2 different specimens. This is the second one. And the second one has a better cell block. So in the cell block, again, these typical cell cluster are really scant. So our job is to identify the correct origin of these typical cells of these metastatic adenocarcinoma. Is it coming from the lung? So it's more common for the primary pleural effusion, or this is coming from the gynecologic tract. So we would need to do TTF1 for the lung primary and PAC-6 for the gynecologic primary. So we would do the imidostem for this case. So the final, the next specimen is also coming from the pleura effusion. So for this specimen, you see more proteinaceous material in the background. Sometimes a lot of this background can really like masking the legionel cell that you want to see. But our screener are still doing a good job that identify these type of cells. So again, we do have cell with very similar morphology, three-dimensional architecture. However, you can appreciate that it shows more of these luminal border type of pattern. This looks more like intestinal instead of primary lung, right? So the patient do have a remote history of colon cancer. I think it's 5 years ago or something like that. And he have not, she is a she, okay. She has now a very big tumor in the lung. And they don't know if this is coming from the lung primary or this is coming from the prior history of the colon cancer. It looks more like intestinal type though. So again, for this case, we will need to check if this from primary lung or if this from the colon. So we will need to do TTF1 for the lung as well as CDX2 for colon. This is the cell block. I think the tumor cells were very, very scant here. It's very difficult to identify. Possibly this cluster is cancer. So a little bit difficult to confirm which cluster is actually cancer cell because it's kind of scant. But anyway, we will still do the IHC, and because we are not so sure if we have enough tumor cells here, so we will also do a MOC31. I think this is the tumor cell, yeah. So we need to do some lineage-specific marker to help our clinician to confirm that if this is a second primary or this is a metastatic disease, because the treatment approach would be totally different. So this is a pleura effusion specimen. So again, we have very, very scant typical tumor cells. So this is high grade, definitely, and with a very tight, small cluster. If this is what we have, it is very difficult to guess where is this coming from. However, the patient do have a past history of breast cancer. So I think this is compatible with breast cancer. Yeah, so we will sign out as positive for carcinoma and with a history of breast cancer. So the next specimen is coming from lung. This is an aspiration specimen, a touch imprint specimen. So we do have a lot of tumors, a lot of cells. So we do have hypercellularity. The cells does show nuclear atypia and arranged in a glandular, like a rosette type of pattern. So this is consistent with adenocarcinoma, and the morphology looks like primary lung cancer. And there's a concurrent biopsy. The pathology stands for TTF1 and P40, but this won't be squamous cell carcinoma. So I think we can safely sign it out as adenocarcinoma just by the morphology. So sometimes in the lung aspiration specimen, you will see these histiocytes with a lot of dark pigment. These are actually carbon particle that coming from the air pollution. So this is that we call anthracosis type of pigment. And you can see it sometimes in the alveolar macrophages. So next one, this is a bone aspiration specimen. This is coming from the spine of an 82-year-old male. So usually for the bone aspiration, for the normal bone aspiration, we will only see the bone marrow element, which is hematopoietic population. For this case, we do start to see these very tight, small cluster of cells. So this looks abnormal. This is three-dimensional, arranged in a rosettes. The cell is a little bit enlarged, but it's the atypia, the degree of atypia is not very high, probably just mild to moderate. And with these small rosette type of feature, in an elder male, the most common scenario for this morphology would be metastatic prostate cancer. So I think the patient do have metastatic prostate cancer. So this is positive for adenocarcinoma. We will just need to wait for the biopsy to confirm that it is prostatic origin, but this looks like prostatic origin. So finally, let's take a look at some the pap smears. This is coming from a 37-year-old female, so relatively young. As you can see, the background mostly are superficial cells with very scant intermediate cells. So this is coming from a young patient with prominent estrogen effect. So we see a lot of these overlapping of the cells, and here we do see some of the cells have like increased size of the nucleus. And then we start to see some of the cells do have coelocytic change. And these type of cells are not difficult to find, it's quite easy to find. So here you see a classic cells with multinucleation, hyperchromasia, enlarged nucleus, and a coelocytic change. So this is consistent with a low CO morphology. And we do have plenty of these cells. We do not see any cells with higher NC ratio. So this case can be signed out as low CO. So this is a typical low CO case. The next specimen is kind of tricky. This is coming from a 49-year-old female. So on low power, you can already appreciate that the specimen looks like it's coming from an elder female with an atrophic pattern. So for the atrophy, the intermediate cells usually would be more in like a tight cluster instead of individual cells. The NC ratio will be slightly increased. The size of the nucleus would also be increased. So this is common in the postmenopausal atrophic patient. So the background is totally different. And for this type of specimen, especially in atrophy patient, it is not uncommon that we can see some bigger cells with matched chromatin and with naked nucleus in the background. We call these blue blobs. And this is a common finding for atrophy. However, for this case, I think it is kind of difficult to make judgment that if these are truly parabasal cells or these could be high CO. I think the staining for today is a little bit bluer. Yes, I think for some of the cluster, I think this is okay. This is just atrophy. But there were some other cluster that I find it's kind of a little bit difficult to determine. So in this situation, our differential diagnosis is between atrophy versus high CO. And then the most appropriate diagnosis would be ASCUS high, right? ASCUS cannot exclude high CO. So these are likely just parabasal cell. However, some of the cell does show some atypia that I'm not very comfortable to just call it benign. And as well as some of these keratinized cell. Yeah, so I think it's better that we just call it ASCUS high. So the clinician would manage ASCUS high patient as a high CO, usually they would go for colposcopy for biopsy for confirmation. And if the patient have some question about that, maybe she can also do HPV testing. If it turns out to be negative, she can just be safely followed. Okay, so that's for all the case for today. Thank you.